Okay, Miss, sorry.
No problems, no problems.
Dramas at home, but they are all sorted. Pleased to say. So you were saying you're in Croydon?
Yes, yeah, absolutely in Croydon, just working away doing perio and implant dentistry out of Croydon. Right,
just exclusively perio and implant?
Yeah, so specialty in perio at the Eastman, and then, yeah, do a bit of...
when did you qualify? How long ago you specialised?
2011. Yeah.
Oh, a fair while. A fair while. So when Jonathan Lack was still there?
Yeah. Dr. Lack was a good friend and first and foremost a great teacher. So lovely guy.
Yeah, I mean I've worked with Jonathan for probably 25 years now.
He's an amazing guy.
Yeah, no, he's lovely. He's great. He's great. And how's your peri-implantitis coming on? Not yours.
That's kind of booming, and a lot of I get a lot of referrals for stuff that is not savable. So we're doing a lot of, well, we try and save what we can, but there's a fair amount of explant, allow it to heal.
What's your take on why it's so prevalent?
I just feel like there's a lot of people that are doing implant dentistry off the back of it being for some of the wrong reasons potentially, and potentially a lack of training going into some of these things. Yeah. And then certainly just understanding some of the risk factors. So there's certain places that will probably place lots of implants without kind of probably assessment of certain risk factors, and then.
I mean, I'm finding a lot of it. I mean, but even it's obviously there's multifactorial, there's bone metabolism.
Absolutely, yeah.
Things as people get older, things can change, can't they?
Yeah, absolutely. And it's not all just us. There's patients that take a lot of the responsibility there as well. So
sure. I mean, there's a lot of maybe cementitis, but also not thick enough a gingival type. But then I don't know. So my mother-in-law, who's 78, had a couple of implants, all fine, and then suddenly 2 years ago, pockets started developing.
Absolutely.
Yeah, tricky.
Maybe, should we crack on?
Yeah, I'm ready. I'm good when you are.
Yeah, we'll do you want me to give you a brief introduction, or do you want to kind of do a bit yourself?
I'm happy for you to do it, but I mean, just a short one is fine.
Yeah, so David, for those that don't know, he's an amazing dentist that heavily involved in and previously in the BACD. A lot of probably famed for a kind of extreme makeover. We have a kind of mutual friend and lab technician, Tony Knight, and he and Tony's doing some more stuff with on the telly, and you'll probably see all that kind of stuff as well. But I think first and foremost, just a highly committed dentist to preventative and aesthetic dentistry and minimally invasive, and hopefully we can get some tips and tricks on what we can do to improve things. So David, the floor is yours.
Thank you very much, Mish. Welcome everyone. So I have been qualified 32 years this year, and 24 of those years were in the same practice. So it gives one a very good grounding of what works in the long term and what doesn't work. And the title is also because I gave part of this presentation at the BACD, which was our 15-year anniversary a year or two back. And so that's what I titled the things I'd wish I'd known 15 years ago. But generally, it's about different techniques we have for minimal intervention, because whatever we do, however well we do it, it's going to have a lifespan. And so the less we can help the patient enter the restorative cycle, I feel the better. So so just a couple of disclaimers. BACD, I was the second president, and I'm accredited by the BACD, which is a great qualification. It's corny, I know, but it's a journey, not a destination, and quite simply made me a much better dentist going through that. I do quite a lot of CFAST, anterior tooth alignment, cosmetic orthodontics. We're going to talk about that because that's a very powerful tool. CFAST are not sponsoring me, but I do a lot of C-files, but there are other brands out there which I'm happy to talk about. Obviously, TIFF works with IAS. There's Quick Straight Teeth. Obviously, the original to come over 6 month smiles. Some different ethoses, which we'll touch on, but generally cosmetic ortho. And I use a lot of DMG products. I think they're a great company, and I use their products because I think they're great products. And so I will talk a bit about those as well. I know a lot of our American colleagues show family pictures, and my purpose is not to show family pictures. My purpose is actually to show how things change over time. And as we know, kids grow up, it's challenges on many levels, but things change with time, things age, me included, as you can see. So I think it's very important that we bear that in mind of how things are going to look down the line. So really, that's why I'm focusing on really what we can get the maximum aesthetics with doing as little as possible to the teeth. And I'm not saying we shouldn't prep teeth. I'm saying we should be responsible in the treatment that we do. But I think we should remember that not everything is wall-to-wall porcelain. Absolutely not. So this is a referral patient. She's 19, very heavily built up central, and we felt that was time to go to porcelain. And just because it's difficult to do doesn't mean that it's something we shouldn't try to do. And with the advent of E-labs and cross-polarization, shade taking is still challenging, but should be getting a little bit easier. And we can receive results like this. Now, that is a referral patient. This is the day we put it in, which is why we have a little bit of bleeding, and I couldn't get the patient back to take any photos, but that's what we can achieve with the materials we have and with skilled technicians. Again, we shouldn't forget the simple dentistry. So bite wings, essential. I'm essentially a GDP, as much as I do a lot of extensive restorative and aesthetic. And I'm taking bite wings every 2 to 3 years, and that's the longest I'll leave it. If there's higher risk factors, maybe sooner. And we know that once we get to the dentine, this is only going to spread out. So if we have a look at that, these were taken with an intraoral camera. We can see the caries into dentine. This is it cleaned out, although we are going to get rid of those margins. I was still in the day when we were taught chisels, but there are other ways to do that. But we want to tidy up those edges, a sectional matrix, and then we can build that up. But again, tiny details. The difference between this and this is 10 or 15 seconds with a soft flex disc. And this is much more preferable to that, and really takes very little time to finish it off to the most ideal standards. I'm also a big fan of indirect. Direct very much has a place, but sometimes we need cuspal coverage. And so indirect composite, or probably now Emax onlays, although these were bell glass, to help reinforce, because there's a limitation of what we really should be doing potentially with direct. And I don't use amalgam, mainly because in this day and age, I think there are better materials, but you can be sure that these ditching margins, these are leaking. And the amount of amalgams we take out, we see that they're leaking. So don't be surprised if you're not seeing this on your x-rays, but you take this out and you will find leakage. And so we need to be aware of when to intervene. So we're going to cover lots of different aspects. We're going to look at whitening, both internal and external. We're going to touch on ICON. And a lot of this is an overview. It's not really meant to be detailed, but I want you to be aware of all the different options. So we have ICON, resin infiltration, enamelplasty, which is sometimes just simple reshaping. I'm not a big fan of cutting down a tooth. The patient comes in with a small chip on a central. Can you smooth down my other central so it matches? And I would say no. You're then going to have 2 short front teeth. So I much prefer building up, but it does have a place, particularly some lower incisors, as long as it's very minimal. We look at composite bonding. We're going to look at that's mainly edge bonding. We're going to look at veneers. We're going to talk about porcelain veneers, but I will touch on composite veneers and some new techniques that we can look at there. Short-term ortho, be that fixed or anterior tooth alignment. Aligners as well obviously have a place, and we'll talk about that. Soft tissue recontouring, so that's non-osseous with lasering, or if we don't have spare biological width, We'll look at aesthetic crown lengthening. We're going to talk about implants, reverse frenectomy to help with the gummy smile, and touch on Botox fillers and osteotomy, but really they're mainly so that we can be aware of those as options that we have. So Jamie came to see me. He was a month short of 18, and that makes it easier because with our whitening regulations, strictly speaking, we shouldn't whiten people below the age of 18, although if we can say there is a medical reason, then potentially that is okay, and certain protection organizations will defend you if you're doing that. And I think as long as the patient's aware that I am actually often happy to whiten an 18-year-old with complete disclosure and full consent about the law, and that strictly speaking it's not legal, but we can do it because it is safe. That isn't the doubt isn't whether it's safe. It's a legislation issue imposed upon us by the EU about whitening patients under the age of 18. So when I've got a case like this, I'll always whiten first to reduce the contrast between that very definitive white lesion there. Obviously, we're aware we're going to have to redo this composite. And there are people who do a lot of lecturing on ICON, Linda Greenwell, Richard Field, did great presentations. And they would say that really we're expecting this probably not to respond that well to ICON, because ICON is only going to penetrate the outer 50, maybe 100 microns, because each time we put on the hydrochloric acid, it's taking about 10 to 15 microns, and DMG are reckoning up to 6 passes. So it's not completely non-invasive, but we're taking away maybe 100 microns, which is pretty minimal. Richard has shown some cases where he will prep and then ICON the deeper layers, so he doesn't have to remove as much tooth. But Jamie was 18, so we made the decision that we were not going to do any drilling. We were going to assess the result when we'd done a minimum of 6 passes. I think we did a slightly more. And then we knew that we would actually probably just layer on some composite without prep. So a good, reasonable whitening result. And again, the contrast is less. We can see where we've had to we're going to redo the bonding here. And this is our final result. And this is where we've just laid on some composite. So by no means perfect, but this is 0 prep. And so I think a very good starting point. And he's very aware that if that degrades, that we can redo it. We can certainly even consider some preparation. And obviously we've got the alternatives should we choose to in the future. But again, 0 preparation in an 18-year-old, I think it's preferable to start cutting that, because he's then in the restorative cycle. Composite maybe 5 to 7 years. So he's looking at a significant number of replacements in his lifespan. And again, sometimes we can think that we can not just add, we can do some enamelplasty. And this young lady worked for an American company when they're over here, Monroe Sutton. And we were looking, and if we apply our principles of smile design, we can see that her width to height proportions are very long. So we know that these teeth are longer than is the ideal, but we also have a lot of incisal dominance. And I wouldn't want to reduce these completely. I think we also need to build up the laterals. So how can we show that? I think it's important we're demonstrating that. So here we're building these up with just a mock-up, and we can show the enamelplasty. And here we've actually done it, but another way is to take a black felt tip pen and draw that on the tooth, and just gives a simulation. So again, I'm a big fan of showing what's possible before we do anything non-invasively. So here we've got our post-op result. We've reduced the incisal dominance, haven't taken much off, but built these up with prepless edge bonding. And if I'm doing edge bonding, I know a lot of people advocate a bevel. I'm fine with that. It's very minimal, but I would prefer to do 0 prep. And I find that with the correct technique, we can brush that in and get an infinity margin, even without placing a bevel, but obviously bevel if you so choose. So if we're looking at whitening, again, I then found out what was happening here, because in fact, someone had built up this in composite. I'm not sure if they didn't have many shades around, but obviously they had used the wrong shade. And just removing that, we're already significantly better. Now, in the pictures you'll come up, you'll see why they placed the bonding, but I would question whether that was actually necessary. So that's our whitening result. For me, there's lots of systems out there, some more premium than others. Enlighten being a premium brand, it's a great product. They spend a lot of time looking after their gels, but it is more costly. It's nicely branded. There are other gels that can work very well as well. For me, also, it's about tray design. I will use a super sealed tray, which has effectively a sealed CEJ if I think the patient's getting sensitivity or has sensitivity issues. Otherwise, I'm quite comfortable with a simple no reservoir trays, straight cut 2 to 3 millimeters past the gingival margin. But even with that, if we can score a little margin on our model, a little bit harder with digitally printed models, but if we can ditch that, we're going to effectively get a seal in our bleaching tray, which can reduce sensitivity. But again, we're getting predictable results, A1, B1. And then made the decision, did we need to build these up? And actually, the patient wasn't getting sensitivity, wasn't too concerned by this pitting. So we elected to actually leave that. And again, a big cosmetic change without doing very much at all. Removing this, by the way, composite, I'd be removing with Softflex discs. Softflex XT, that's the extra thin, which is the dark red going to light yellow colors. Again, different case, but very simple, just a little bit of whitening and just a little bit of a class 4 composite. Again, not perfection, real world dentistry, but very big improvement for this patient. Again, zero preparation. Internal whitening, I do think it has a place. My only concern is whether it fades over time, but as a starting point, I think it's a great option. We've got Aisha here who's 19 and non-vital central incisor. I don't really want to be prepping that. And if I'm prepping that, I know it's going to get darker as I prep it. So I don't even think of veneers necessarily appropriate. If we're going to do anything with that, it's going to be a full coverage crown with all the inherent difficulties. So I much prefer to try internal whitening. Again, our legislation means that whilst we could seal in some peroxide, we're technically not allowed to. So I now will use the in-out bleach technique, where I will take the GP down to 1 to 2 millimeters below the CEJ, and then I'll place a glass arm plug to protect the gutta perca, make sure it's sealed, and also limit any risks of peroxide getting into the cementum and out onto the ligament, because that is the only indicated or the only times we see potentially resorption. So a plug, and then I will leave that access cavity open, and the patient will have a whitening tray with reservoirs front and back on that single tooth, and they'll be instructed to change that bleach every 3 hours for about 3 days. And in that time, we will bleach the color out of that dark tooth, and then patient can continue whitening everything, including the darkened tooth, so we can get a very reasonable result. Again, non-invasive. Just be aware of internal whitening. That's if we have a non-vital tooth. Sometimes we might have a dark central incisor or a dark front tooth that is vital, and it's dark because it's had a secondary, tertiary dentine laid down. A reasonable technique is external whitening of that single tooth, and that can also work very well. Obviously, internal is if the tooth is non-vital. I would not devitalize a tooth to try and internally whiten it. If it is that tooth that's had trauma, we'll notice that from a sclerosed canal. Then we'll do whitening on that single tooth initially before we whiten everything else. And again, another example of internal whitening. What are the alternatives? And the patient originally attended because he was planning to change the bridge for the shade, for shade reasons. So we talked about the uppers, and we then internally whiten these two teeth. Again, not perfect, but a significant improvement, and doesn't preclude other options. So those are non-invasive. But if we're then going to be doing something more invasive, how can we communicate that with our patients? And initially, cosmetic imaging is available. I know Tony Knight, who's one of the many labs I work with, but Tony is excellent, very experienced, and he can do imaging, or there's obviously now DSD, digital smile design, Photoshop, whatever you choose, but it's always going to be a simulation. So I'd much prefer to be able to show something in someone's mouth. And so for that, I'm a big fan of doing quick composite mock-ups, and I'm going to show you some of those. I say quick is because it really doesn't take long. My objective with the composite mock-up is to show patients what I can see in my mind's eye. So, for example, it might be lengthening lateral incisors, as I showed you with a little bit of composite, or even flexible. It might be a facial mock-up for a peg lateral to show them how we can make some differences. And I'm making the assumption that we're all aware of smile design, and smile design is an essential part, must understand that to help us be able to communicate. But also it might be widening the buccal corridor, and to put some composite on it and shape it really takes not very much time. I personally predominantly am nearly 100% Venus Pearl for my composite build-ups, mainly because I think it's a great product, and I love the handling characteristics because it doesn't slump, it stays where you put it, but it's still thick enough to be able to sculpt and mold. But ultimately, the aim of a mock-up is to take the patient to a wax-up, be that a conventional wax-up, be that a digital wax-up. I will then have a putty matrix of that, and then if I'm putting that with Luxatemp, and we'll look at plenty of examples of this, we can show patients exactly how we are previewing the initial smile. I'll often contour it, but show them what it can look like without touching their teeth. And then obviously building up a portfolio of similar cases is very useful. So here we have an imaging case, a case that's many years old, and you get an idea of, we can show people what's possible by widening the buccal corridor and putting things in proportion. So that's the image, and that's the actual completed case. I think it's always worth having a disclaimer that an imaging is just that, it's a simulation and is not going to necessarily be as accurate as the final dentistry. So patients need to be aware of that. But here, and again, a historical case, we have lengthened these teeth because there is a recession. Are we going to get grafting to work on that? Unlikely once it's been prepped. And here, almost certainly in this day and age, we would be pre-aligning that and probably not doing veneers, but again, properly prepared, we're widening this out. That is still going to be completely enameled. But imaging can be difficult to do, and there's a bit of a steep learning curve. And is the dentistry achievable? And only looking at a simulation, not a picture, not a 3D simulation. Although with DSD, obviously, that is getting much more accurate. So looking at mock-ups, and the purpose of the mock-up is to help a patient visualize what I am seeing in my mind's eye, so they then move forward to an actual wax-up. And I would never dream of doing a case, be it composite or porcelain, without doing a wax-up. But we'll look at the different workflows for both materials. So here, Kathleen, I had done some previous bridge work posteriorly, and she came to me and said, I feel my teeth are a little bit worn. I don't like the gap. Is there anything we can do? So we said, look, well, let's mock it up and show you what I'm seeing in my mind's eye of how we can make things look. And that was enough to help Kathleen move forward. I should say that we have to be very careful when we're taking photos. This is shot upwards, so it makes it look here like there's a reverse smile line, which you can see, in fact, there's not. But this helps the patient move forward, and this is our final 4 units porcelain veneers. And there's Kathleen as a full face shot. So again, Sonya came to see me again many years ago now, before her wedding, and she said, what can we do? And from an informed consent point of view, this is very powerful, because we can just look at masking the 3s as laterals. However, not a lot of incisal dominance, still the chipping on here. And so we said, right, well, we can provide you with a little bit of incisal dominance, more, and obviously the shape is not great here, but it's just to give the patient an idea. We're making these into lateral incisors, but the patient didn't like the recession or abfraction, didn't like this rotated premolar, and wanted to go lighter than she might otherwise have been able to do, doing a smaller number of units. So here we have Sonya from pre-op, preps, And again, this is before I was doing the Gorel technique. So these are still enamel, but I think we've probably prepared these more conservatively now. These are our prototypes, our trial smile, which can be modified, adjusted till we're completely happy, and the patient's completely happy with the final aesthetics. And the bottom right here is our final porcelain veneers. So patient's gone from there to there. Okay, so the point here is not so much the final result, it's showing the patient what's possible so she can decide what works for her. And my mantra when I see a new patient is I'll meet and greet, we'll talk about their concerns, any timescales, and then I'll take a full set of photos, but I'll explain to them that my job really is to give them all the information to make the choices that they feel are right for them. So I'm going to educate them, show them what's possible. I'm not going to tell them what they should do. The only thing that's non-negotiable is health. So obviously we have to be making sure periodontally they're healthy. We've got stabilized decay, no active caries, and not active caries ongoing. And then the treatment is largely elective, what they choose to do. So how do we go about doing a wax up? And historically, there were two ways. I would now only consider additive wax up. So a reductive wax up is, give me one moment, sorry. Sorry, teenagers. So a reductive wax up, where we actually prep the model for veneers without due consideration necessarily of where the veneers are going to end up. And whilst that can be very accurate, and you can see the comparison. So the top is my working model. Sorry, the top is the laboratory prepared model of how they envisage my veneer preparations. And this is my actual working model. The issue with that is that if we're being additive, why do we need to reduce the front surface of the tooth at all? So for me, I'm never doing reductive wax up these days. I'm doing a completely additive wax up. And so I'll explain to a patient that if I'm putting a veneer, a porcelain veneer on the tooth, I'm going to expect that thickness to be about 0.5 millimeter. Now, it's rare that we can add the whole 0.5 millimeter without making the teeth over bulky. And I do say to patients, we don't necessarily want to turn you into Ryland Clark, which generally brings a smile and reassures them that we're not aiming to give them the biggest teeth possible. But we do want to be additive, because whilst it's rare to be able to add the whole 0.5 millimeter, we can always add, and I say that because I've been doing this for nearly 20 years now, that we can always add 0.2 or 0.3 of a millimeter without making the teeth too bulky. I'm going to show them what that looks like with a visual try-in, so we're going to confirm that, but generally we know that we can add 0.2 or 0.3. Now what that means is we're only having to reduce the tooth 0.2 or 0.3 of a millimeter. And that means that we can pretty much guarantee that we're going to be 100% enamel, which is our aim. Because veneers work best long-term on the enamel. And I think in this day and age, the days of over-prepping teeth and relying on dentine bonding for long-term success, I think is not great, because what happens after 7 or 8 years is that dentine bond, if there's no enamel, tends to degrade from the water trees, and so veneers often will start popping off after about 8 or 9 years if they're dentine bonded. So I think we need to be completely enamel, and an additive wax up allows us to achieve that. And so we can see here we've been additive, and you can see that therefore we're going to be conserving quite a little bit of facial enamel. And I'm going to demonstrate to a patient what that looks like, as you'll see, with what I call a visual try-in. So we're going to have a putty matrix. I am a fan of these V notches. I think, as you'll see some cases go on, we can get some very precise visual try-ins and demonstrate to people what things can actually look like. So here, a visual try-in involves no tooth preparation. A visual try-in is different from a trial smile. A trial smile is what a patient will leave with once we've done any veneer preparation. so that we can preview the smile. A diagnostic try-in, a visual diagnostic, is to visualize that process and show patients where we're heading and check that we're in the ballpark of what they're expecting. So I don't send the patient away with a visual try-in. I know Pascal Magnier will often send them away for a week. So because I'm not sending them away, I won't spot etch the teeth, whereas for my trial smile, I will spot etch. The reason I don't send the patient away is that the most powerful part of this appointment is taking the visual try-in off. So we're going to do an additive wax up. It's not just the buccal corridor. Okay. So here we have Shane, and Shane was unhappy with his teeth. He felt there were small teeth. They felt they made him look younger. He felt the gaps made him look like he had sort of baby teeth. So here, and often a visual try-in is as much for me as it is for the patient, because I want to check before I'm touching their teeth that we can get things in the right proportions the way we want them to look. And obviously here, I'm concerned that we're going to have to be making these teeth relatively wide. I want to check that Shane is happy with that. So the lab here have shown me where I'm going to be doing some lasering to improve the contour here, because the contour of this is not ideal. And we're going to effectively be mesializing this tooth a little bit. So we want this gingival contour to be a little bit higher so the tooth can have a better emergence. And so this is a visual try-in. We're taking Luxatent. We're putting that in our putty matrix. We're putting that over the teeth, and then we will remove away the excess from these V notches. And I should add that they do a hands-on program where we do this in detail. I've just done one with Kushal Gardia at ACE in Stanmore. So again, an overview. I'm not here to promote any courses, but I do a hands-on course where we look at this in a bit more detail. And that's enough for Shane to say, yes, that's what I'm looking at. Now, the fact these canines are wide, because we're looking them facially, and you'll see from the side that we can mask that with a correct position of the line angle. I would point out the slight shine through here, which is going to be relevant as we progress through the case. So here we now are progressing on to our day of preparation. So a visual try-in happens in advance, but I will then use the visual try-in to do a technique first described by Galip Gurel, called the Gurel technique. I call it the Gurel technique. He calls it aesthetic pre-evaluation. But for me, it is a way of ensuring we're only prepping the teeth where we need to. So here we've done an additive wax up. The lab will be instructed to add 0.2, 0.3. If I think it could be a prepless case, they can add the whole 0.5, and I can check with the patient that it doesn't look too bulky. And similarly, if a patient comes in saying, I want prepless veneers, I can do an additive wax up. I can put this in their mouth and I'll give them a mirror and they'll say lovely, or they may say they're too bulky. And I say, well, that's because I haven't made space. So we either have to accept that they're bulky like that, or you let me prep your teeth. So again, from a consent perspective, very powerful. So here I'm going to be doing 0.5 depth cuts. Until the advent of Emax, I was largely felspathic because we could be slightly more conservative, 0.5 as opposed to historical pressed more like 0.7. However, Emax now can be 0.5 or even down to 0.3 if you've got a good underlying stump, but I'm, well, foundation shade, but here I'm depth cutting 0.5, but notice not at the cervical. Why? Because generally we've only got about 0.3 enamel at the cervical. So if I'm depth cutting there 0.5, I'm immediately beyond my enamel. So I'm not a big fan of the three depth cuts. This is a single wheel. We'll put that in place and we'll highlight the pencil marks. And then I'm going to do my incisor reduction. I'm going to take my burr. I'm going to measure the diameter of my burr, and I'm going to insert in that in 3 places, 1, 2, 3, and then I'm going to level that off. Now, if this is the facial plane of the tooth from the lateral view, so this is where our veneer is going, very important that when we prep that incisor reduction, that we keep it flat or slightly angled this way. What we don't want to do is angle it to the palatal, because why? That will give us an undercut, which only allows us an incisal path of insertion. Whereas if we prep flat or even angled this way, we can have a facial path of insertion. So we're much less concerned about any bulbosity on the facial, which means, again, we can be more conservative. So here you're going to see one side reduced, both sides reduced. We then take off our Luxor temp. And the only places we need to do tooth preparation facially is where we have our pencil marks. So remember where we were shining through on the canines, we knew we'd have to do a little bit more preparation there. Now, so I think they should be restricted to enamel. Dentine long-term is going to reduce our bond strength. We spoke about 0.5 millimeters, and we said that that's why we're not depth cutting cervically. So here with Shane, we're taking that off, and we're only interested in our pencil marks. Now, this was one of the first cases I did. It's very conservative. I think I would do it even more conservatively, but we're only prepping facially here. Now, interproximally, my preferred margin is not to break contact. I will take my micro chamfer, and Tony will tell you that is barely a scratch at the gingival margin. The days of having a big J chamfer are very much over. If we can do prepless cases and have margins that are cleansable like this, then if we have a micro chamfer, that's absolutely fine for the lab to work to. So I will take a micro chamfer, I will take it into the papillae, follow the contact round, but without breaking contact. However, where I have a diastema, I will take a slice to the palatal because I want the emergence to be able to come from the palatal. And so taking a slice allows my emergence to come more from the palatal, which the labs will tell you is much easier for them to close diastemas. So here the left-hand side is prepared, the right-hand side isn't. I think probably didn't need to round it as much here. It's still very minimal. This is where we've had slight nick, but we can control that with some either retraction paste or viscostatic, hemostatic agent. The Optident turns blood to mud. Here we've done a little soft tissue lasering to enable us to have emergence slightly subgingival, so we're not having black triangles. So this is our prep, this is our pre-op. And the only place I think it possibly could have done slightly less prep is these areas, but it's still very minimal. So that's Shane before, Shane after. Okay. And looking there, we can see where we've got the slightly wider canines, but from the facial, that's looking okay. And if we go close up, we can see here how we've changed that. Okay, now the eagle eyes of you may notice this little crack line. This was probably nearly 15 years ago. And this is a material called VM9 from Vita. And these were made on platinum foils, and we cemented them all. I'm cleaning the cement up here. We go back here, and suddenly I see this crack has appeared. There's some sort of contraction, shrinkage, and fault in the material. So I let Shane know about that. I said, obviously, I could redo that. I believe it's internal. So I'm not concerned, but if it's ever an issue, I can redo that. And that is Shane. And if we consider how things age over time, this is Shane, who emigrated to Australia. He contacted me and said, do I know a good dentist in Australia? And I said, I hope it's not that lateral incisor. He said, no, I need some general dentistry. My veneers are still fine. But if we see how things change, that's why we need to be aware of how things change. And I'm pleased to say that Shane has very much grown into those, and that is 15 years later. Now, longevity-wise, I think patients very much need to understand that whatever we do, however well we do it, it's going to have a lifespan. And I'm going to say for porcelain veneers, my life expectancy is 10 to 15 years. Now, we know it can be longer, but that's an average. I think the very big important difference is if we're looking at composite veneers, we're talking about 5, possibly 7 years. The difference is they are typically half the price, but they're going to have half the longevity. But you can see how that lateral incisor, it was all internal. If I was going to replace it free at the point, and the reason I didn't want to replace it is from shade matching point of view, these are made by a hand powder mix and just adds a risk that things aren't going to match. And you can see that that ultimately was the right decision. So buccal corridor, quite a well-known picture. We know who did the dentistry. I won't go into that. I wonder why, because they're a good dentist. They know what they're doing, but I'm not sure why you would do that to someone. And in fact, this was the origin of the Friends sketch, I believe, where Ross's teeth were glow in the dark from whitening, which was a bit of a Mickey take. But that's inappropriate planning. But here we have to be aware of it. So patient came to see me and said, I don't like my midline diastema and I think my teeth are a bit flat. And we said, absolutely, we can work on that. But something you're not seeing is that this side we're seeing teeth, this side we're seeing less teeth. And she said, thank you for pointing that out, but it's not a concern for me. But again, pre-warned is, so we know that we've discussed that with the patient. And so here, once we deal with what the patient's concern was, the 4 units, now that becomes much more apparent. But the patient was very comfortable and wasn't concerned by that. And that's our 7-year recall. And in fact, that's an 11-year recall. Patient was kind enough to send me those pictures to say everything was still going very strong. She had moved to the West Country and wondered if I could recommend someone to do a full mouth rehab for her husband who had a lot of wear. And we did, and because we were in contact, she said, oh, I've just had some shots done. Can you, would you like some? So absolutely, and that's the shots. I used the BACD network to then find an accredited colleague who could help her husband. So again, this is a referral that came to me from BACD website, and a patient, a young vet, came to see me and she said, I don't like my smile. I said, what don't you like? She said, I don't really know. I just don't like my smile. And if we look at it on the surface, she's got lovely teeth, but they do slope in, and therefore it makes these teeth look more prominent than they otherwise might do. And so very easily with some composite, I mocked these up, and honestly, that took me a couple of minutes. There was going to be some alignment issues, but for us to look at what she didn't like, that wasn't something we needed to focus on initially. And so here, all I've done in these 2 pictures is direct mock-ups on the 3, 5, and 6. She's had 4 premolar extractions. So here I'm premolarizing the mesiobuccal cusp of the 6. So we're looking like we've got premolars, and by no means perfect, but enough for the patient to move forward to say exactly what I don't like. How can we do it? And these are going to turn out to be prepless veneers. Why? Because we're being completely additive. So we did pre-align. We did a little bit of edge bonding on these lower anteriors. If I'm aligning, always fixed retainers. Retention is essential. My good colleague Asif Chatu said to me, I think has a great line. I will credit him with it. How long do I need to wear a retainer? As long as you want to retain the result. So retention is long term. I personally, I'm not a big fan of just giving a patient an Essex retainer and say wear that at night for the rest of your life. I think that's a big ask. But equally well, I will never just give a fixed retainer. I will give both and stress that the patient should be wearing the Essex a couple of nights a week. But if anything happens with the fixed retainer, they can wear the Essex at night until we can repair it. So here, aligners, a little bit of edge bonding, possibly could do with a little bit more polish, but again, and here we're then looking at temporaries, our prototypes. So initially, this is a visual try-in. Here, where we're just showing the patient what it can look like. We then did this prepless, but I would still make the patient a trial smile that they leave with, so we can preview the final result. And I'll do a review appointment and a separate appointment. So here, what's wrong? I wasn't happy with this premolar having been built out quite enough. And looking at it here, the patient was very happy generally. I felt this could be improved, but also the patient felt that this lateral was a little bit skinny relative to the other. And so again, a little mock-up here. It's too wide, but it's giving the patient the idea. And in fact, the patient elected to a prepless veneer on that lateral incisor as well. And here we have our post-op result. This is the day I fitted them. They had been dehydrated, so these are a little bit lighter. But you can see we can achieve a more refined version of what we were showing with our direct mock-ups and then ultimately our wax up. So I'm also not a big fan of 6 units. I'm going to show you how 6 units can work, but this comes back to buccal corridor. And this wasn't my work. This is how the patient came to see us and really hadn't been appropriately treatment planned from a smile design perspective. But to show 6 units can work. So this is Ben Foden, who's a rugby player who was marrying Una from the Saturdays, and she asked me to do some work. And here, I felt 4 units would be too big. The reason 6 units can work is we can see that we have a well-developed buccal corridor, and we know that by adding a little bit to our canines, we can improve the flow to our buccal corridor, and we can link everything together. So here, I want to make sure that 6 teeth are not looking too bulky, particularly with regards to the laterals. So this is a visual try-in, 0 tooth prep, just to confirm to Ben that this is achieving what he wants, and he confirms that. So here, we're using our Gorel. These are the depth cuts I was talking about. Now, because of the slice, they do end up with a little bit more prep on the centrals than might be considered ideal. However, 100% enamel, which is what's important. So those are our preps, our foundation shade, and then these are our fitted final veneers. And again, with the correct emergence profiles from the paleta, which is why we have the slice, we've not got black triangles. And so that is Ben's final result. And we can see, yes, we've got long centrals. He wasn't concerned about that underneath his lip. His lip is never going to go any higher. So he was fine with that. And those are our final veneers. And that's him pre and post-op. So I consider it mandatory to do a visual try-in before I prep any tooth. And the reason is this patient came to see me with a big midline diastema. So I said, we can look at doing 4 units here. Let's see what they look like. And we did 4 units. And sorry, we did a full smile because that allowed us to widen out the whole smile and be additive. And I'm not saying the patient's wrong for a moment. The patient said, that's fine, but I feel my teeth are a little bit sort of square and squat and too bulky. So we spent a lot of time recontouring that. So we thinned everything down. We took the line angles closer together to create illusion that the teeth were thinner and longer, and we lengthened slightly, okay? And we achieved this. Now the patient says to me, now they're too rat-like, too long and skinny. And the reality then is that I don't think I can do her case. And I tried to explain that to the patient. The patient said, no, David, I know you can make it okay. Well, the fact is I can't, because she doesn't like either way. And God forbid I'd prepped her teeth, I'm not sure where we would go. So I explained to her that really she needed some ortho to redistribute that diastema, and then probably only 4 units. And she wasn't prepared to do that. And so I didn't feel that I could give her the result that was going to please her and that she would be happy with. And again, I'm not saying that they're not too long and too skinny. Some patients would be happy with that. Some patients would be happy with this, but she wasn't happy with either. And we felt that there was no halfway house. So I think it's much better that we step away and we say, well, I don't think I can achieve what you want because at this stage I haven't prepped her teeth. But also 4 units can be diagnostic. So this is a patient of mine, a young doctor, and I felt that we were always going to be getting a better result from doing 4 units because we could be more additive and we could improve the proportions of these laterals. And so we did 4 units, and the patient, as is entirely his prerogative, said, that's great, but can I see what 2 units look like? So we took them off and we looked at 2 units, and he said, okay, I can see why you were thinking 4 units. And so again, diagnostically, the patient can understand that I'm not trying to sell them extra units, but I'm trying to give them the best result, and they can visualize. And if he's happy with 2 units, I'm happy that I've shown him what can be achieved, and 2 units, if that's what he wants, he can have. But here we went to our 4 units, and that's our final result. Interesting in this case because patients do learn how to smile slightly differently when their smile is done. And he was just had a review a month ago, and he's absolutely delighted. And for a young doctor to say you've changed my life, I think is always very pleasing. We shouldn't underestimate the power of prototypes. So Lorraine came to see me many years ago when I was actually working in Scotland, and she'd had some pre-existing bonding, but she didn't like the bonding. I think someone had done a reasonably good job, but she had spaces, and she felt it was time to to progress on. And so what's interesting here is that I'm doing a visual try-on. Now, another colleague worked in the practice, and the patient had made a mistake with the diary date, so he'd come in and he had done a visual try-on, and the patient had said, well, I'm not proceeding. And I was very confused by that. So I rang the patient and said, can you let me do your visual try-on? And it turned out that there were some aspects that she didn't like. So I recontoured that. And what that gave her is the confidence that I could make changes to the smile to a point where she would be happy with the smile. And she said, well, I do want to make changes. I just didn't know that we could make the adjustments that I wanted. I showed her that. And so we decided to proceed. And so the patient then said, well, can I have spaces between my teeth as I originally had? And I said, you can, but not today, because I want you to see with no spaces. You come back for your review and I will give you spaces, and then you can have whichever you prefer. But I want you to see both sides, and I think it's important that I show you without spaces, and then we can show you with spaces. And so here we have our prototypes, and even with this was actually at our diagnostic try-in, our visual diagnostic. She said, can you put spaces in? I showed it, and that's what gave her the confidence that we could proceed. So we then did her trial smile. Okay, so we've done our minimal preparation. We'd have done a Gorel technique for this, done our minimum preparation. Here I'm exaggerating the gingival embrasures because I want to make sure that she can get pink teepees in to clean in here, because we need absolutely excellent gingival health for when we come to cement our veneers, because often I will cement without rubber dam. I know that sounds like heresy. I do use rubber dam, but if we've got good gingival condition, we don't need to. And the issue with these ultra thin veneers is that they tend to get the seating pattern from each other. And if you seat them individually, which I have done using a butterfly clamp, if one veneer is slightly out of place, it's going to put all the others out of place. So my preference, as long as we have good gingival health, is to rapid cement all together, because it allows us with correct positioning. Because one of the downsides of doing minimal preparation is that we have less positive seat, and so we have to be careful about our seat. So the patient said, well, can I have those spaces? And I said, you can, but we're going to start without. And then she came back and we said, right, we'll put the spaces in and you decide. And she came back and said, you were right, I don't want the spaces. And I said, it's not about being right, but that's your decision, that's great. And so these are 8 Emax veneers. Now, I'm not generally a big fan of 8. In fact, this is one of the rare cases you'll ever see I do 8, because I still think there's a bit of a step here. But the patient's quite happy. You can see how we can get the natural translucency built in with our Emax. And so this is our veneers and our final occlusal shot. Now, what's interesting here is that this is on the day they were fitted. We did a 3-year, I did an 8-month recare, sorry. This is an 8-month recare, and the patient at Lorraine is still not entirely comfortable and hasn't learned how to smile. She then tracked me down and wanted me to check things out 3 years later, and we can see now how she learned to relax into her smile. And all I'm saying in these pictures is smile, and now she has learned how to smile with her new veneers because she feels comfortable and relaxed with them. We should also be aware we are in the age of digital. And so I looked at this patient. Now I happen to be doing an all-on-4 with the very talented Guy McClellan and CDT Mike Fuse. And I just had this case, and Mike looked at it because I was going through some cases, and he saw it and he said, well, do you know, I think I can do something for you with milled PMMA. So sort of moving on from a visual diagnostic is actually to make some temporary veneers. So he milled some PMMA veneers, he had them linked and he had them separate. And I put these on and said to the patient, this is what we can achieve without drilling your teeth. What did you think? She said, absolutely, I want to do it. So we moved ahead. Apologies, picture's a little bit out of focus, but these are 100% prepless veneers. And from here, life-changing for this patient without drilling her teeth. And again, it's just a step on from a visual try-in. We knew that we were going to be prepless, so we milled the PMMA temps so we could show her what they look like. And here, again, apologies about the focus here, but we can see what we've done and what we can do and achieve for patients. So not everything is porcelain. I mean, I think gold standard for me, if we're doing veneers, is porcelain. Composite veneers very much have a place, and I'm going to touch on smile fast a little bit later in the presentation, but not everything needs to be porcelain. And I first started doing smile makeovers some 20 plus years ago when a gentleman came over from the States, Larry Rosenthal. Now, Larry got a lot of bad press, but at the time, that's how we prepped veneers. We were prepping them more than we absolutely would prep them now. And the options were, well, we can do the veneers, or you have to have ortho for generally 18 months. What we didn't realize is that actually we can do adult anterior orthodontics in a considerably shorter time. So Tiff, when he was scientific convener for the BACD, brought over a gentleman called Ryan Swain, who was running 6-month smiles. And that really started the ball rolling and helped Tiff get started with the Inman aligner. And Tiff has now moved on to also teaching fixed, but really anterior tooth alignment. Now, for me, I'm a GDP. I'm not changing malocclusions. I'm unraveling front teeth. So why, if I start widening buccal corridors, I've got to move the lower teeth. I've got to settle the occlusion. So for me, anterior tooth alignment is predominantly 3 to 3. Obviously, the brackets can do a lot more. And if you have the training, feel free. If you've got unopposed teeth, we can widen the buccal corridor. But for me, 3 to 3. What that means is I can unravel teeth in as little as 4 months using fixed tooth-colored buccal brackets. I will use aligners. I do use aligners. Aligners very much have a place. They work. The problem is patients need to wear them 24/7, remove them to eat and drink anything except water, and we have refinement issues. So generally they're going to take longer. We will use them. I don't mind if it's fixed or aligners, as long as the patient is aware of what we're doing. So as I said, I happen to use SmileTrue. CFast SmileTrue. SmileTrue being their aligners, CFast being cosmetically focused adult straight teeth. I really work 3 to 3 because then we're unlikely to detrimentally change the occlusion. Now, anterior guidance absolutely matters. I'm not suggesting we're losing anterior guidance, but we are modifying it. We don't move premolars because we look at passive bracket placement. Absolutely work within your skill set and only do something you feel comfortable with. Take the further education. The reason CFast, I think, are very good is that they have a forum and the lab won't let you start a case that they feel is not suitable. And I still work very closely with Bijou, who came up with CFast because he was doing 6-month smiles. And the classic story goes is he asked the patient to close together, and the patient, I can close together that way. He'd had a posterior, an anterior open bite from moving posterior occlusion. So we're much less likely to get in trouble if we stick to 3 to 3. CFast happens to be labial predominantly. It can be O-ring ligation, but O-rings discolor. So they have a great self-ligating bracket. I absolutely do lingual, but predominantly 3 to 3. Lingual ortho very much has a place, and Asif is great at doing lingual ortho. I can do lingual ortho if I'm only changing 2 1 1 2, because generally we're only bonding upper 3 to 3. So limited cases, but I'll show you a case or two. And aligners, I am Invisalign certified. I have no problem with Invisalign, but it's quite a costly system. There are other cheaper aligners such as SmileTrue. So how did the short-term adult ortho work? Same as really we're looking at brackets and wires, different brackets. This is an O-ring ligation. We have tie wings, bracket slots, arch wire slots, I should say, orientation dots and tie wings, although that's if you're using elastics. And generally, we're not going to be using a lot of elastics because we're not changing occlusion. And this is a self-ligating bracket, which means we don't need O-rings. And again, I stress this is not promote CFast, it's to promote anterior tooth alignment as being a minimally invasive technique. So self-ligating, the wire, nickel titanium with a tooth-colored coating. The wire wants to be a perfect C shape. The wire's attached to the bracket's attached to the tooth. The wire pulls the bracket and the tooth into the right position. We have indirect carrier systems, so you don't have to worry about bracket positioning. And therefore, we can be sure that we've got the best bracket positioning. So we know that with anterior tooth alignment, what movements can we do? We can do tipping. We can do bodily movement. We can do intrusion, very powerful, because when we intrude or extrude, our gingival margins are going to come with the tooth. So we can actually make some big changes with intrusion and extrusion. And we can also do rotations. The one movement I'm not trying to achieve is torque. And the reason is I'm not using square wires. I'm using round wires in a square slot. So you don't have the power to do torque. Now, these brackets, it is possible to use those with root torque if you are prepared to then extend your treatment by probably up to 3 months. And you're working up to an 022 stainless steel, but you can't work up to that straight away. It'd be too powerful. So that's why it's about 3 months. And yes, you can move up to that, but I'm electing not to torque. And if the patient, if that needed, then that's what I'll be referring. Absolutely, everyone should be offered comprehensive ortho as the gold standard, but often adults aren't concerned about their slight malocclusion. If they've been functioning and there's no other issues, they want to uncrowd their teeth. So here's an example of the limitations if we don't torque a tooth. This is actually Bijou's case. And what we tend to get is we tend to get flaring. So the emergence is not as ideal. That's before and after. But if we look at that at full face, okay, and yes, we could even do some recontouring here, but that tooth is tipped rather than root torqued, which is why the emergence is slightly off. So be aware that that's one movement we're not trying to achieve. Tiff coined it ABB. We prefer ABC, which is align, bleach, and correct with either ceramic or composite, often minimal or prepless. So just to very quickly show you some cases. This is Alba. I've shown this to orthodontists. They don't believe that was done in 7 months. So arch wires, we use bite stops. I only use bite stops to stop people biting off brackets. So we don't need to use bite stops to allow us to correct or reverse overjet here. What's going to happen is the teeth will come edge to edge, you'll be a bit uncomfortable, and then they'll come forward. So here's Albert after 3 months. After 4 months, we're just about establishing a positive overjet. And the other thing we can do on the lowers, if we need to, is a little bit more IPR, power chain to bring those lowers in to help us achieve the positive overjet. And I'm not going to go through all the wire sequences, but CFAST is still running courses. The course is a day course. It's not to teach you to be an orthodontist. It's to help you understand the system and, most importantly, understand case selection to get you started. But obviously, you can't learn ortho in a single day course. So here we are at 5 months, 6 months. Here, the patient has been quite vigorous with their brushing, so they've taken the coating off. These are just quick ties to help secure the brackets in. Now, this is the only case I think I've ever used elastics. Why? Because I knew it was going to be a great teaching case. And elastics here and here are going to help settle this occlusion. So you can see when we are finished at 7 months, our debond, we've improved our interdigitation. Possibly we've had elastics for a little bit longer, but functionally, I'm happy we've achieved everything. So that's our pre-op versus our post-op. I think retention is essential. As I said, how long do I need to wear a retainer? As long as you want to retain the result. So retention is long-term. My preferred is a fixed retainer. You can get these made from jigs in the lab, but I will tend to make it as a direct fixed retainer that I will place using orthoflex wire. We want this passive. We don't want any wire that's been heated because it can act as an appliance if we're not careful. But I would never rely just on a fixed retainer. As I explain to patients, however well I do it, there's always a risk it can debond. And so I want you to have something that you can wear at night for the first 6 months and then a couple of nights a week. If the fixed retainer comes loose and you wear the removable, nothing will move until I fix it. Problem is sometimes a fixed retainer can come loose and you don't know about it, which is why I want you to wear it a couple of nights a week, or ideally just try it in so we know it's still fitting. So that's Alba before and afterwards. And again, maybe just 4 or 5 cases to give you a flavor here. Obviously, we've got some information, some differential tooth wear, and I'll speak to patients about aligning first, and then as Tiff coined the phrase progressive smile design, they can then decide if they want to do whitening and if they want to do edge bonding. So here we aligned Alice's teeth. Yes, ideally, I'd like to build up this disto incisor of the upper left one, possibly the laterals a little bit. Alice wasn't concerned. For her, it was a great result. She's very happy. And generally, we're looking at 4, maximum 6 months I think she was about 4 months. And that's Alice before and after. This is a lingual case. So when I was working in Harley Street for a few years, patient came in to see me, and she was ironically a footballer's wife, and she said, I would like veneers. And I said, that's fine, but I don't think you necessarily need veneers. And if I give you veneers, you're into the restorative cycle, you're always going to need them. She said, well, what are the alternatives? And I just started discussing braces. She said, I can't have braces on the outside. We started talking about aligners. I can't be doing that. It's too impactful. So if we look at the position of her canines, they're pretty much ideal. The issue we have is 2112. So we bond these up with a mini ST, which is what CFast use. It's a self-ligating bracket that's got a little gate that opens and closes, a little catch. And the long and short of it is, this is a different case, but it's just to show you, because when I did this lady, I didn't realize we were going to be using this for lecturing, so I didn't take any pictures, but this is another lingual case. This is a catch that opens up. And again, nickel titanium with cinch back bend here, 3 to 3. So same patient after our anterior tooth alignment. Okay. Now, patient did want to go very wide, and so this was in fact enlightened and extended enlightened for about 3 to 4 weeks, and I think that's a pretty good result. Now, she also had some mottling. We did a little bit of ICON to reduce those, and so we've gone with our fixed retainers from there to there. Patient's delighted. 0 tooth preparation. For me, I look at this and it looks like a buccal corridor issue, and in fact, it's not. It's predominantly buccally placed 3s, and by aligning those and very gently tweaking the premolars within the confounds of the occlusion, we can get a dramatic result. So we've got some anterior crowding, but buccally placed 3s lowers the same. Same patient, 6 months worth of CFast. Okay, does she need anything else? Possibly additive here. For her, absolutely not. And again, we're not doing anything to her teeth, we're moving them. So that's her before. Yes, some aspects that are not completely perfect. You could even do some gingival recontouring here, but fine for the patient. So that's our fixed retainers. We can even bodily move canines. So Rupert came to see me, and you can see what the issue is when we have a look at our occlusal views. And we know that we can bring this canine out. Now, it's not the first case you do, complicated wire sequence, because we're going to be having an 018 and a piggyback, an 014, which is a much more flexible wire to bring that out. But that's where we took the patient to in 6 months. Okay, so again, tried to get him. He did have whitening, although he never proceeded with his whitening particularly. Didn't proceed with his edge bonding because he was delighted with the result he got, and he didn't feel there was a need to take it any further. But you can see now where the canines come out. Again, you look at this and you think that Sarah had a tooth size arch discrepancy, that the ones are too big relative to her lateral incisors. And in fact, the issue is it's very much that they're in standing more than, there is a slight discrepancy, as you'll see when we look at the finished case, but it's more that they are in standing and the crowding. So here, fixed ortho. And you can see what result we can get in, again, a short time frame. And I'm finding more and more that these cases are generally 4 months rather than 6. Again, with some things we have to be aware of, which is in very crowded teeth, slightly older patients, we are likely to get black triangles. Now, this patient was quite happy, felt it was underneath her lip line, didn't bother her. Various different ways we can look at that. And whilst there are the BioClear, which was historically called the Clark matrix, they have a place, but I find that they often will make these teeth unnaturally bulbous. So I'm not a big fan. So if this was an issue for the patient, I'm going to show you what we can do, but we can basically provide some IPR, pull those teeth together, effectively changing the contact as per Tano's work to closer to the gingival, the papillae height, and so we can have infill. And so here we had a case that we were predominantly treating for black triangles. Patient's concern was the black triangles, and I said, okay, we can deal with those. We can look at bonding. She said, I don't really want bonding because then I'm going to have that. And again, I often feel that they become quite bulbous looking teeth. So here, all we've done is provided IPR, squeezed the teeth together, and dramatically improved that those black triangles to a point where the patient is delighted and not having to have any restorative work. So that's really short-term ortho. Now I'd want to look on to sort of moving on to the DAR concept and some other concepts. So if we look here, the patient's occlusion posteriorly is great. The issue is we have anterior tooth wear 3 to 3. So what can we do about that? Well, what I'm going to propose to this patient is that we're doing effectively on the upper 360-degree composite crowns, and here just some crown lengthening, and we are going to open the patient up just on his anterior teeth. What that is going to leave is a posterior open bite, but we know through the research that basically what's going to happen is over a period of 3 to 6 months, 3 to 4 months, the posterior teeth will tend to over-erupt, the anterior teeth will get intruded, whether there is some slight settling of the condyles, but we know we can re-establish his occlusion. So here, again, zero prep. Nowadays, I would probably use that using a stent, probably with pre-separators, which is SmileFast. But in fact, Tony did these stents for me many years ago. And basically what you can do is alternate teeth. So you can do the 3, the upper right 1, the upper left 2 as one stent. And that would be a suck down stent, a 4mm suck down stent. So it's quite rigid. And I will do those, and then we'll build up the other 3 teeth, or you can do the teeth one by one. The advantage of a stent with pre-separators is we can do all together. Now, the only issue I had is I don't know what I was thinking when I was planning this, but I hadn't planned to do anything on the lowers. So I didn't have a wax up on the lowers. And here I was doing them individual teeth. The wax up is on the lowers, so I built these up freehand. So this is freehand composite with just mylar strips, which we've built up. And you can see the extent we've built these up. So the patient has gone from here to here. And you'll see that we have, we can have our post-op. I thought I had a post-op view, which was showing a slight posterior open bite, but that re-established. And once we then have the posterior teeth re-established, this composite will probably degrade over time, okay? But then what we can do is we can remove that, and we have magically created the space to upgrade, if you like, upgrade to porcelain, which is always going to last much longer than our composite. So given the choice, I think porcelain is our gold standard, but it is more costly and generally will involve some tooth preparation. So if we have an 18 or a 20-year-old who unfortunately tend to watch TOWIE and Love Island, and so very much want pearly white teeth with square embrasures, which isn't always possible with edge bonding. So the advantage of a composite veneer is that it is largely prepless because we can add less volume. So again, I'm not here to promote it. I'm sure a number of you are aware of it. Just be aware of this as a treatment modality. I'm just going to quickly run through it. Separated stents, heated composite, okay, developed by Midday and Tom Seeley. And it is a digital workflow. So there is a digital wax up. This is Tom's case. I now have done about probably 10 myself. Just haven't inserted them just because Tom had these for me. So the important thing is that we're going to provide this as a trial file. So what I would call the visual try-in is part of the SmileFast process. They call it SmileFast Refine, and that is modifiable because once we make the stent, that's going to give us our final composite surface texture and our finish. So we don't really want to be adjusting that. So any adjustments we make the SmileFast Refine, we'd either recontour it, add flowable, take a new scan. We can retry that if necessary. But ultimately then we're going to move on to make our stent, and this is that same case, okay? So this is the heated stent, sorry, the stent with the pre-separators. We take a heated composite material, and then there is the evacuation grooves. They are using Empress Direct, which is also a very good composite. The fact that it's being heated makes it, all of them going to have similar characteristics because it's going to flow very well. Different composite heaters. This is by Connor's company, Connor Bryant Dental. There are different heaters around, but this has a specific temperature. And just to show you some cases, that's before, obviously some pre-existing composite, which I would remove. That's our digital wax up. And you can see how much has been added. Okay, they will send back, this is the putty stent, the digital wax up. Often whitening as well is included, just because then you don't have to be sending your scans and your impressions to more than one lab. They are very cost effective, mainly because they're not really trying to make a profit on the whitening. They're just providing that as a service. That's our putty matrix, allows us to do our visual try-in. I'm glad I'm not the only one who doesn't clear up their alginate until they take their photos. This is Tom's photo. But again, that enables the lab to make the stent. PTFE, packed, patient anesthetized, a little bit of gingival retraction, heated composite, paste, heated, flowed, evacuation grooves, take this off, contour it up. You can see the texture they're achieving. It'll remove the excess. There's various burkits by Tom and Midday. And this is just the contouring. So it does look a little bit traumatic. This is where we've taken the PTFE out, okay? But this is the healing. Now, patients very much need to be aware this is not going to last as long as porcelain, maybe 5, possibly 7 years. It's not going to keep its luster, but it's half the cost. So for me, porcelain veneers in the region of about £1,000 a tooth. Composite veneer, although Smile Fast like you to do it as a package price, recommend a package price. That's going to work out sort of £500 a tooth, so half the price, half the longevity. My job is to give you the information to help you make the choices that you feel are right for you, no right or wrong. But if patients do ask me, I'm generally going to say porcelain is going to last them longer and is generally accepted as the gold standard, because as you can see from Shane, can last many, many years. And that's the workflow all the way through. The tooth wear case, again, we can see how we built them up. Now, for me, I've also done this on a patient that had extensive tooth wear, and doing those as 360-degree full coverage, as I showed you with a gentleman we did as the doll. And then we're opening them up, knowing that then that is a definitive restoration, final restoration. But when the posterior teeth re-establish, if we chose and the composite eventually deteriorates, we can remove all of that, and magically we've created space to do porcelain, should we choose to. So just looking at some of the other techniques now. So reverse frenectomy, or known as a lip drop. So someone has a gummy smile. There are many reasons for gummy smiles. We need to be looking at that. Is it a short maxillary lip? Is it hypermobile upper lip? Is it the fact that the maxilla is in the wrong position? What we can do, though, is we can always make the teeth the right proportions. And these teeth are width to height ratios probably of close to about 100%. So we know that we can improve the gummy smile by crown lengthening. Now, in fact, I'll show you the pictures. I think I probably slightly over lengthen this, because we're always saying how much can we reduce it, but we can never completely reduce this gummy smile, because we'd give her super long teeth, which would be completely anesthetic. But what we can do is put the teeth into our ballpark where they're the right proportions. So here we've done some surgical crown lengthening. Now, I think the width to height ratio is probably a little bit long, but the patient was happy. So when I'm talking about just soft tissue diode laser, I'm talking about where we have spare biological width. So the biological width is from the edge of the gingival crest to the osseous crest. And that needs to be 2.5 to 3 millimeters. So if we put our probe in there and it goes in 4 millimeters, we know that we can remove 1.5 millimeters of spare tissue without encroaching on the biological width. However, often we find that we don't have that spare biological width. So there are many techniques for surgical or aesthetic crown lengthening. I'm not talking about the old crown lengthening, where we would literally go all the way around the tooth to provide some mechanical retention. And as you've seen now with the advent of dial and additive techniques, I think that is largely, not always, but largely superseded. Still has a place, but we'd be using it a lot less because we'd be using other techniques. But aesthetic crown lengthening, we're just changing the buccal contour of the bone. So I will laser to the ideal gingival position. Now, Sometimes I'll do that freehand. Sometimes I'll have a stent made from my wax up from the lab. That doesn't have to involve facial wax up. It can be asking the lab to measure the proportions and make a suck down stent that makes it easier to scroll. Now, the reason I do that is that if I have over lengthened those teeth or made a mistake, I'm responsible. I don't think it's necessarily reasonable to put that on the periodontist, because the periodontist's role is to recreate the biological width. So I will laser to what I consider the ideal, and I'll ask my periodontist to then take a measurement from the incisal edge to the gingival crest. We know that generally that's going to be 10 and a half to 11 millimeters. Okay. What they will then do is that they will, and I will know where I'm invading biological width because I've made that diagnosis. I will ask them if they're in the same clinic as me. It will happen the same day. I will laser. Then it will be tag team. The periodontist or the surgeon will step in, measure from the incisal edge to the new gingival position, raise the flap, and put the osseous crest 2.5 to 3 millimeters more apical than that in a dome-shaped semi-lunar, just so we're contouring, keeping the contours, and we're not risking creating black triangles by removing bone around the papillae region. If the periodontist isn't in the same clinic as you, then biological width is not going to be invaded in a matter of days. It is a second appointment, maybe a second anesthesia, but it can be done where the patient leaves, not having the osseous recontouring done, visits the periodontist, who will then do the same, measure from here to here, and then raise a flap, put the osseous crest 2.5 to 3 millimeters higher up, and reposition the gingiva in the same position. So that's our crown lengthening, but we're still here left with a gummy smile. So my first port of call then would be to suggest the patient has some Botox to preview the final result. And Botox can be the definitive treatment, but obviously it's going to need to be repeated every 3 to 4 months. So it's very good to preview it, and if patients are prepared to have that every 3 or 4 months, they can continue. But there is an operation where we can actually effectively sew the lip down. So we take out the unattached gingiva up here. It's quite a difficult procedure, and the rule of thumb is you take about 3 times as much as you want to reduce the gummy smile. So if we're saying that's 3 millimeters, you're going to take about 9 millimeters of unattached gingiva, which is not an easy thing to do because it's sort of floating around, but it can be done. And so this was done by Peter Fairbairn many years ago, and I think it's fair to say he probably didn't take quite enough, but erred on the side of caution, which is not unreasonable. And so is that significantly better? Yes. Is it perfection? No. But the reverse frenectomy, sewing the lip down, can be revisited should it be necessary. So just finishing off with sort of some lateral thinking cases. So Dana came to see me because she had some previous bonding, and she said, can you revisit my bonding? And I said, yes, I can. But if we're looking at everything, I would like to point out a couple of aspects, because you already have some spaces. And she said, yeah, I don't really like those spaces. And I said, fine, but if I'm going to change that, we're going to have a tooth here that's a little bit too wide. And this tooth is not going to be the same proportions as that tooth. And she said, well, what can we do about it? Because I don't want you to prep my teeth. You mustn't prep my teeth. I'm not having you cut my teeth. So I said, okay, well, we can do a couple of different wax ups for you. I can do your wax up to show you what 4 prepless it is. And she said, prepless? I said, yes, we won't touch your teeth. And I can show you what a wax up would look like to show you what it would look like with those 2 teeth just with the spaces closed. And so this is on the left, a visual diagnostic. So you can see how we've refined this now. And this is Luxatemp, not bonded on, just to show the patient what we could expect by doing practice. She said, that's great. And I should say that actually my light bulb moment here was looking at this. The patient said, actually, I wondered, I always thought these teeth are a little bit short. Could they be longer? And that's when I started thinking, well, actually, maybe we could look at practice for this. So we waxed it up, 2 wax ups. Which do you prefer? Visual diagnostic, and show you the model. You can see how the laterals are wider than they might otherwise have been. What would you like to do, Diana? Well, I'd like to proceed with the prepless veneers. So here, believe it or not, she hasn't done any whitening. this is her natural tooth color. But what we have done is taken a soft flex to remove her composite bonding. Okay, we've then done 4 prepless veneers. Again, this is the day of fit. I know I'm not going to have a black triangle here because I haven't prepped the teeth. So this is just where we've had the patient cleaning with TPs, and I couldn't get the patient back traveling wise for she was a governess. I found it difficult to attend, so I didn't get her in to redo the photos, which is why you're seeing this picture. But you can see the result, and that is prepless. So prepless, as someone once said, is ideological, but not necessarily realistic. It's not necessarily achievable in the real world, but it's something we can always strive for. And finally, I think we shouldn't underestimate the power of what we can do for patients. And as Mish kindly pointed out, yes, I did extreme makeover back in mid-2000s when there were a few of us doing that. And obviously Uchenna is carrying that candle now, again with 10 years younger. But it really can be life-changing. And as powerful as doing hair, teeth and makeup, and really genuinely life-changing. So Sue came to see me saying, oh, can you just touch up my fillings and maybe give me some whitening? And she had very heavily restored teeth. She was overclosed. She was getting 3 or 4 headaches a week. And we discussed some of the options. Long and short of it is we ended up doing a full mouth rehab for her. We were replacing, most of these were heavily restored. On the lower, we knew this was underneath her lip line, so we knew that we could finish super gingerly, and she was comfortable with that. And Sue, 20 years later, still comes to see me. These, which were heavily filled, this has unfortunately decoronated, and we've had to replace. In fact, we did elective endo and a little bit of crown lengthening. We managed to get a restoration on there because she didn't want to proceed with implant. But the reason I say it's life-changing is that I don't think really you can put a value on that, because all she's had done is her teeth, and she's happy to tell me 20 years later that that is the best investment she's ever made in her life. We dealt with her periodontal issues, her health issues, but we also improved her occlusion to a point where I have a testimonial from her saying that she's had 2 migraines in the last 8 months, where she'd expect 3 or 4 headaches a week. So we can, as well as cosmetically making some massive changes, we can help people functionally. And finally, a case that's been pretty well publicized. Talisa came to see me, and Talisa didn't like her a very gummy smile, a very narrow smile. It looks like she's missing teeth, or she had restorations here. She doesn't. And I think we shouldn't be afraid to treatment plan the appropriate number of teeth. And so for me, often the numbers are 1, 4, or 10. I'm not a big fan of 6. Equally well, not always a big fan of 8, because I think most people showed 10 teeth in her smile. Talisa showed 12 teeth in her smile. So sometimes it is important to show people that. And again, the visual try-in helps us to communicate that to patients, because I can wax up, be that 12 teeth, be that 10 teeth, and then I can show them what a few extra teeth would look like, or a few less teeth would look like. So if we wax up 10, which would be the most common, I can take off the 9th and 10th unit each side, and I can show them what that looks like. And invariably, there's negative space here, so the smile looks narrower, and we have dead space. So don't be afraid to treatment plan appropriately, but as always, it's explaining that to our patients and getting that message across. And the other advantage of a visual try-in is it's very powerful to do that, because we can remove those extra teeth and show people why we're visualizing the extra teeth. And so that's Talisa's 12-unit mile makeover with a lot of osseous recontouring. Again, I am comfortable bonding onto what ultimately may be root surface. Why? Because I know that I have plenty enamel on the tooth to bond to, and that my seal is enough to stop marginal breakdown and leakage. It's just not enough to rely on for 100% retention. So I'm fine to bond onto what is otherwise root, as long as we've been completely minimal in our preparation and the rest we're bonding to enamel. That was the oxygen bar a few years ago, but again, I think you can see the color in the hair has somewhat changed. So I hope that's been a helpful overview of some of the techniques we have and what I'm using. and allow some time so that we can go over any questions if there are any. So I'm going to stop the share and welcome any questions if there are any.
David, thank you for an excellent presentation. That was really comprehensive and very practical and pragmatic. You can see exactly what you do and, you know, the evolution of some of those cases through the years. So thank you so much.
Thank you.
It's really been appreciated from somebody that doesn't do this at all from a periodontist point of view. We've got lots of questions, some of them in different formats. So I'm just going to go through.
I've got one here that's actually in the chat box.
Yeah.
Okay.
So quite a few.
That was, did you increase the OVD for Shane? Shane was a completely facial, largely additive case, so he didn't need the OVD changing. Interestingly, I really have no problems increasing OVD. And in fact, for a full mouth case, it offers lots of advantages, because if we have a wear case and we're opening there vertical up, and I used to test this with splints now, like Paul Tipton, I'm very comfortable opening verticals, not having issues. If we're opening that, it allows us to be additive facially on the lowers, extending the lowers, and so we also don't need posterior occlusal reduction. So increasing the OVD for full mouth cases is can be very useful, again, because we can be additive and be therefore more conservative.
Is that typically with composite posteriorly and porcelain as anteriorly, or is it?
It's not. Well, it depends, to be fair, on the restorative state of the teeth. I'm not really necessarily comfortable doing full coverage on virgin teeth, but with the advent of additive, I think Emax onlays very much have a place. Composite is a very useful material, and I know there are people that would advocate full mouth. I would just be concerned whether we're going to be long term with that, because I think it's going to wear and it's maybe not going to have the longevity. So I'm not anti it, but I think with partial coverage, I mean, if the patient has a heavily restored dentition, it's an easy decision. We're going to be using indirect. If they have a more of a virgin dentition, I think whether you're doing additive composite, equally well you can do additive Emax. And yes, we're going to put a chamfer around, but that can be certainly, it doesn't have to. I mean, I don't like really tabletop. I'll have some mechanical retention and resistance, but it's going to be completely enamel. So we can be very conservative with Emax onlays as well.
Right. Your thoughts on and place for any, do you use any zirconia at all?
I do use zirconia. The only time I don't use zirconia is I don't really believe we can fully bond zirconia. I know with some of the new silanes that have MDP in them, like Monobond Plus, there is some thoughts that you can bond it. I'm still not a big fan. I wouldn't be bonding zirconia for an onlay. So Emax for me is much more bondable. I use zirconia for monolithic posteriorly because the less layers we have in a restoration, the less things there are to fail. So monolithic zirconia, but I'll also use zirconia as I would a PFM. I think now the labs have got a very good grasp on not having too much unsupported porcelain. So as long as your zirconia isn't leaving a lot of unsupported porcelain, we're getting much less delamination. So I'll use zirconia with Emax, or I'll use monolithic zirconia. But for onlays, Emax that I can hydrofluoric acid etch silanate and know I can very thoroughly bond to the tooth.
In terms of some of the other questions, one of the questions was, what's the best kind of matrix for posterior teeth? What kind of matrix system do you use? Sure, and I think the simple answer to that is sectional matrix. The more complicated answer, there's some great colleagues who do some fabulous posterior composite courses. Corinne de Berth, Andrew Chandrapal, Jason, Monique, a number of them. I think the answer is there are very different sectional matrices. I find most of the time I can work with a Paladin sectional matrix, which is now part of the V3 system from Dentsply, which was originally V3, which is a separating ring that has the V's in, so you can have your flexi wedge go through. And I find they're enough for most cases, but I know some people love the BioClear.
I think the answer is there are different manufacturers, and some people say you can't use one system for everything. I find that the majority of the time I can, because if it's getting to the point where it's that big a restoration, I'm thinking that it probably should be an indirect restoration. Yes, we can do deep margin elevation. Again, I'm not a big fan because I think you're still bonding to root. And so I'd much rather go indirect. So if it's that sort of a restoration, I'm tending to think indirect. So that's why probably Paladin as a single system or whatever you choose, Garrison do some, that works pretty well for me. I think the key is also having different heights. So the Paladin comes as little as 4.5, 5.5, it goes up to 6.5, which has a subgingival aspect as well.
Do you have a favorite whitening product or whitening system that you use for some of these?
For me, it's the answer is no. I have used Enlighten. I think it's great branding. It's a great premium product, but again, it adds cost. I won't say gel is gel because that's unfair on Enlighten because they spend a lot of time looking after their gel. But apart from Enlighten, I think gel is gel. It works pretty well. Yes, there is an element that if it's refrigerated, it's going to be much more active. And I understand that's where the costs go. But the majority, I find that any carbamide, I tend to use carbamide, works pretty well. As long as the tray is well designed, and that's either a super sealed tray with some sort of carving at the CEJ, so the suck down splint has a seal and you get less leakage, or for me, just a straight cut, 2 to 3 millimeters past the gingival margin. So I think tray design is important. Other than that, I'm comfortable with most gels.
And David, in terms of your like day-to-day practice, I'm again just talking practically, how much kind of ABB or ABC, as you kind of said, how much of that stuff are you doing?
It's grown massively. Probably with aligners, 40+% of my practice, maybe even 50. Again, not everyone has edge bonding, not everyone needs edge bonding, but I'll offer it to them. And it means that we can be massively more conservative. So I still do a lot of indirect work or direct composite work, a lot of indirect porcelain work, but pre-alignment has made a massive change. So I think 40% plus of my practice now is some degree of adult ortho. And again, not everyone is suitable for adult ortho. I still refer for a lot of comprehensive ortho. But when you understand the systems, there's quite amazing what we can actually achieve with brackets or aligners for as little as 4 months.
Yeah, I did Larry's course in New York when I first started off with Mike Apper and Larry Rosenthal, and the kind of work we were doing back then was very porcelain heavy, and I can see that there's a big change. But you know, you're doing it day to day. You're still doing a lot of porcelain work, or I'm now talking about the indirect work. How much of it is porcelain based, and how much of it is composite based?
It's a very good question. I think a significant proportion is still porcelain based. I think the difference is, and I think Larry, to be fair, is what everyone was doing at the time. When we started doing veneers, they were pretty much just stuck on. But then we realized that they were bulky, they weren't that aesthetic. So then it's like, oh, we can prep teeth, we can do dentine bonding. And what I found being in the same practice is I find some of these, not many, and they still work very well, but I would find veneers popping off after 8 or 9 years. And I find that those are the ones that were dentine bonded. So that's when I thought this can't be right. And I think, to be fair, there very much has been a general move. I saw Larry a few years ago, and I know Mike Apper is very much more conservative now. And most people will aim to pre-align if possible, and certainly much more minimal prep. But it's what was the norm 20 odd years ago. However, I still do a lot of porcelain work. It's just treatment plans slightly different from an additive perspective. And so the answer is still a lot of porcelain work, but I think we need to be aware of all the different options. And as I said, I'll give the patient the choice. They might say, which would you recommend? And I try to shy away from making a recommendation. I'll try to just reiterate the pros and cons. I think what we'll find is that composite veneers, as they start to deteriorate, it's still a fair amount for the patient to go through. So when they're redone, I'd be surprised if that many opt to have composite veneers a second or third time, because they're going to be redoing them every 5 or 7 years. So I think we'll find that it's a very good start. It's a lot less cost, much more of an entry level. But I think we'll find over time that when they come to be redone, people will start to opt for porcelain again, so they don't have to have it redone as often. But even with porcelain, we're going to get, you know, as a periodontist, we're going to get gingival height changes. We see exposures in the margins, and that's probably why they're still going to need it redone down the line. But the answer is still a fair amount of porcelain, but I'll let patients choose.
Does that speak to the consent as well? So when you're actually consenting patients, is it do you strongly mention all the different options within the consent and then go through this is the option that you selected?
And again, I'm not a big fan of consent letters, because I think what they're showing us is people say, well, I didn't understand it or I didn't read it. And you give them a consent and they go, yep, sign it. And then you say, no, you've got to sign every page. Sign every page in front of you and don't read it. So, I mean, Bijou has come up with a product which I think people are starting to be familiar. I Consent You, which is where they watch a video and then answer questions on it. But yes, I'll make sure that they understand the different options, which is ABC or the differences between certainly an additive wax up, but an additive may mean that I can often do composite prepless, which has its advantages. But the flip side is it's not going to last as long. They're going to need it redoing, but it's going to cost them less. Or they'll allow me some degree of preparation. And if they say, well, I don't want you to prep my teeth, again, the visual try-on will show them that they're going to have bulky teeth unless they let me prep their teeth. Or maybe they are a prepless case, which is great if they are, but then they're not that common. So I think from a consent point of view, going through that process and making sure that they understand the differences is very powerful.
And is that kind of covered in, I mean, if you're not getting it kind of in a written form or as robustly in a written form, are you doing it more in form of your clinical notes and saying that, you know, we've gone through these kind of options and so on, and this is what you've chosen, and using the mock-up as a form of consent?
Very much so. So my notes will discuss the fact that we've been additive, to what extent we can be additive. And I don't think our notes can ever be good enough, but we can get pretty close. And it's really a question of, yes, I'll explain it to them, I'll put it in my notes, and do you understand that? Maybe repeat it back, all of those tools. But yes, making sure. But again, by doing the mock-ups, by doing the visual try-in, I think it would be difficult to accuse us of not having gone through that process, because the whole point of the process is to demonstrate and not to go straight to cut their teeth. And so visual try-in is always, if a patient travels to see me, which is often the case, I'll still do the visual try-in. I will do it at the beginning of their appointment, and I'll explain, I'm allowing you 3 or 4 hours. And if for some reason this doesn't turn out to be right, we can do it as 2 separate appointments. But if you want to avoid that and you want to travel, I am going to ask you to cover that surgery time to an extent, whether we proceed or not, but I'll still do it at the beginning of the appointment. Obviously, if we've got our smile design correct and we've got our diagnosis for our wax up correct, there shouldn't really be a reason why they wouldn't proceed. So that has never happened, but I'll still do it in advance, take photos, make sure they understand. And it's powerful because they can see us being able to recontour. And again, that's an essential skill. And I can't really think of many cases where I don't make some modification. And some patients have a very keen eye. Sometimes we might have to do 3 or 4, even 5 recontours, because, and a patient best described it to me. I said, I'm a little bit confused because I thought every time you leave happy. And she turned around and she said, I leave happier. And so we go through that process until they're completely happy with the aesthetics. And then you need a good lab like Tony who will be able to then copy that. And it's not easy. I'm not saying it is. And even in this digital age, can we completely automate that process? And the labs are finding that difficult, because even with drops, it can be difficult. We're working on it to do it without. But generally, it's going to be a pair of hands doing some sort of micro layering. And that's when the issues can come in. And so you need a lab that are meticulous about measuring, checking line ankles, taking lots of putties so that it is an exact copy. But it is possible and should be possible.
Yeah. Laura asks, which bonding system do you use for cementing porcelain veneers? What's your bonding protocol and what?
Great question. So I am old school in that I am still 4th generation. So by that I mean total etch, separate prime, separate bond. Okay, so the 5th generation is a single bottle system. So OptiBond Solo, prime and bond NT. The problem with those is the research tells us that whilst that is still a good bond, it's not as good a bond as a separate prime and bond, because the prime penetrates much better if it's in a single bottle. So I am total etch. By that, I'm removing the smear layer and then I'm putting prime on, and I'm using OptiBond FL, and I'm painting prime on and I'm reapplying it and reapplying it. And I'm thinking that the dentine is a sponge, that is literally to get the hybridized layer, as much penetration as I can get on that, the better. So I find OptiBond FL, which has separate prime and a separate bond, as my gold standard, and I think reality shows that as being the gold standard. Of course, there's some people who like selective etch. I think the self-etching primers, where we're modifying the smear layer, be they the 7th or 8th generation, some people like them. I think we know that they're not good enough to etch the enamel. They're fine to condition the dentine. So you end up sort of just selectively etching the enamel and then self-etching both of those. And if that works for you, that's great. But for me, I don't get any sensitivity with total etch. And I think predominantly because I don't just apply the bond once. I apply it and reapply it and reapply it. And so I get a very good hybridized layer. Then I paint on the OptiBond FL. Now, the only thing with FL is it does have filler particles in it. So for indirect restorations, it's a good idea to air thin it, so you're not getting any pooling. But to date, I haven't had an indirect restoration that doesn't seep because of OptiBond FL. So my preferred is OptiBond FL. When it comes to veneer cements or indirect cements, so a zirconia crown, a monolithic zirconia crown, I'm going to cement. So cement as we would a PFM. 30 years ago, we did use zinc phosphate. Now I'm using resin modified glass ionomer or pure glass ionomer, but I prefer resin modified. So I'm using GM Fuji Sem or Fuji Plus for cementation. For bonding, I'm going to use Total Etch, OptiBond FL, and then I like Vitique as a veneer cement. If I've got enough light penetration, they do it as a dual cure, which now is called Permacem. But obviously there are other manufacturers. Ivoclar do their cement, which the name escapes me for a moment, but it will come back to me. Vitique, no, not Vitique, a Verilink. A Verilink is fine. I find it a little bit stickier. I prefer the handling characteristics of Vitique, but that's a personal preference. So if I'm bonding, I'm using a resin cement, be that light cure or dual cure.
When you say that you're applying the bond onto the dentine and you're seeing it as a sponge, do you air thin each layer, or do you continue to just try and use them?
I continue to apply the bond, and then I will dry it. And so then the difference is I will put a 3-in-1 when I finish my prime to just air dry it. When I'm putting the bond on, it's partly drying it, but really I want to thin it because I don't want any pooling. And the prime doesn't need curing. Whereas if you're doing a single bond system, you would have the prime and bond in one, and you would cure that. But the research, I think, is pretty clear that you don't get as good a penetration of the tubules until you don't get as good a hybridized layer.
Fair enough. Any recommendations on the polishing kits with composite?
Yeah, that again a very good question. I think we can achieve an awful lot with Softflex. So not the dark Softflex, but the lighter ones, which is XT. The dark ones are cardboard back. They're very thick and they're quite aggressive. So I use XT, and they come in red and they get slightly lighter now. 3M call that coarse, medium, fine, and super fine. I call it 1, 2, 3, and 4. 1 and 2 are cutting, 3 and 4 are polishing. And you can get a very good polish with that, and then couple that potentially with Astropol from Ivoclar or Kulza, do some composite polishers. But in fact, since I've been on the Smile Fast course, I think there is even another polishing system that I'd recommend, and that's Eve Twist. So Eve Twist is available. I forget who the suppliers are for the moment, but Eve Twist gives a great polish to composite. Obviously, porcelain, we're hoping not to adjust. But if I'm adjusting that, Brasseler do a good porcelain polishing kit as well. But composite would be those, and potentially finishing with an Eve twist. There are other systems. So Cosmodent have their FlexiBuff wheels and their Enamelize, which is a polishing paste. But all of those are options. But I find with the Eve twist that probably using less polishing paste than I used to.
A topical kind of question is, are you doing any kind of virtual consultations or kind of pre-consultations to your kind of, if they're coming from far away, and had you know, kind of discussion?
The simple answer is I'm very happy to. I was doing a lot more during lockdown. Now what I tend to use virtual for is a ClinCheck type aligner review, because I do still travel to 4 clinics, and some of those are a fair distance. And so I have no problem doing a virtual consult, but it's never going to be a replacement. And so with a good TCO, I find the TCO is doing a lot of the virtual consults for me, so that the patients are coming in, it's a salesy word, but pre-qualified in that they know what the different options are, they know what the costs are, so they've had a chance to assimilate and have a think about it. But I don't have a problem with virtual consultations, but I don't see why a TCO wouldn't do that, because ultimately I'm going to need to see the patient anyway to physically to assess everything completely, photographs, radiographs. But what I do find Zoom is very good for is a ClinCheck, because that does save the patient a visit and frees up my diary. But even with that, I will email the practice. I'll either record it and ask for them to be okay with I'm recording it, or I'll email the practice with everything that's been discussed. So I've got it as my notes, because if we are doing remote consults, and when I did Zoom consults towards the end of first lockdown, I was recording them or making notes, because we still have a duty of care to record what was discussed.
Yeah. It's coming up to 9, and so I'm going to hang around for a few more questions, but I just want to let the audience and the delegates know that you'll get CPD for this. So when you do log off, you just need to fill in the form as usual. I just want to also thank the sponsors as well. So Kerr, Denplan, Tony Knight and his lab there are supporting this event. So our Dental Elite. So you'll get the opportunity to interact with them. So tick on the feedback form and do interact with them, virtually, and they will be contacting you if you do, just to give you any offers that they have at the moment. We'll hang around for a few more questions if you do have something, and otherwise I'll let David go. Yeah, I've got 1 or 2 more, but if people do want to kind of exit, they can do, and they'll get the prerequisite CPD. Next month's on practice valuations and how that's changed, and what that looks like from an accountant's point of view, legal team's point of view, and from a broker point of view in terms of buying and selling practices. So that should be quite interesting for first-time buyers or people that are already have a practice or 2 as well. So that should be good next time. Excellent. Final few questions. How often do you walk away from cases, Dave? In terms of, there's a patient that has very high expectations. My question is leading in the sense that there are, obviously, with patients that are cosmetically driven, they will have high expectations or sometimes unreasonable expectations. Do you find that you walk away from, or what percentage of cases do you not treat?
The honest answer is not many, but I would encourage people to go with their gut. And if they feel that, there's 2 aspects. Are the expectations unrealistic? And second is, can you meet them? Now, the harder thing is to be able to meet them. If I can see there's something that I can change, and I'm confident that I can work with the patient and the lab to achieve that, then I feel I can treat that patient. But equally well, it's not just clinical, it's also, can you build a rapport with that patient and can you get on? And what I think we always should be aware of is that our gut instincts are maybe we're not going to establish that correct relationship. And those are definitely patients you should walk away from. And there's also patients under unrealistic expectations, as I sort of showed, is can you achieve that? Well, if I can't think I can achieve it, I won't do that. And unfortunately, some patients can be sensitized by previous treatment. And I'm thinking not just aesthetically, we have the patients who have phantom bite. And the problem is they will come in and they will tend to know best about what they need. And it often flies in the face of what my understanding of occlusion is. And I wish them well, and I'll try to help as much as I can and refer them on appropriately. But if they're not sort of agreeing with where I feel they should go occlusally, there's not a lot I can do. I don't always, but I would absolutely say it's something to bear in mind, and never be afraid to walk away and say, I don't feel I can meet your expectations. I think we need to be professional in all of that, give them all the information we can, not just walk away and say, try and refer them on, but don't be afraid to do it.
One last kind of question to wrap things up. In terms of treatment planning, when you're working things out for patients, do you itemize plans, or do you give a case fee? Because this is something that a lot of people kind of struggle with.
Yeah, I mean, I treatment plan very much in a similar way, is always by health. And so the first aspects will always be hygiene. You know, as a periodontist, very few patients use interdental brushes. And I mean, every new patient, I have to show interdental brushes to, and I show them their gums bleed profusely. And so based on health, caries free, then I will go through the process. I understand why people have case fees, but I tend to itemize because I'm itemizing for myself. So I know I'm putting all the fees down. And I understand why people do case fees, because people can say, well, why this, why that? I think there is some degree of clarity, but I understand both methods, and it again is whatever works for you. And I think there is a move that certainly with sort of the composite veneers, people say there's a package price, and I can understand that is attractive for patients. But I tend to itemize it anyway, and just because of old school, I tend to give that. But I have no problem with either way. And there are pros and cons to both ways. But personally, I tend to itemize. Although you can get the patients that say, well, why is this? Why is that? In some ways, you can say there's more clarity, but it does invite people to nitpick. But it's equally well, it's transparent. And why are they paying for a core? I mean, for example, I've got a heavily restored anterior tooth. We used to put posts in to reinforce the teeth, and then they said that wasn't true. Well, I find actually I do want to put a fiber reinforced post in. Why? Because if that tooth's going to have a crown and the whole of the center's drilled away for a root canal, I want to have something integral inside. So I'm bonding in a post and core, or a fiber post and core, to actually give us more of a monoblock. And I want the patients to know that I'm doing that. So as a global fee, they won't necessarily appreciate that, whereas an itemized fee, they do.
Yeah. And with regards to guarantees, is it how long do you kind of quote unquote guarantee your work?
And that's a good question as well. Most of the time, guarantees are used as marketing tools, okay? Because they come with caveats that if you don't come and see our hygienist every 6 months, your guarantee is worthless. So a lot of the time, the guarantees aren't necessarily worth. As a professional, I'll guarantee anything unequivocally for a year, okay? If they're going to fail, it's going to fail in a year. After that, I would not feel comfortable at 15 months charging someone full price. So I will heavily discount it. And again, I'll have the conversation with them and say, look, it's more than a year. Maybe it's something you've done. I don't want to say it's completely your fault. Maybe it's something. So I will come up with a formula, if you like. And it tends to be that maybe up to 3 years, they might pay 50%. After that, maybe pay 75%. After 3 or 5 years, it's 100%. But again, even if they pay the lab fee or some sort of something to contribute towards the cost, and again, it's goodwill. And I mean, the mouth is a harsh environment, and things but they shouldn't fail within a year, okay? Which is why it's unequivocally. From there, have the conversation, and as long as they're feeling it's reasonable, then you can come to some agreement.
Yeah. One last question for you before I let you go. You've been doing this for so long, and how is it your marketing that's allowed you to continue that longevity of your career, or is it just good word of mouth, or a combination of both? What would you say in terms of this current era? How do you keep doing cosmetic dentistry?
I think, if I'm honest, I did work in one place, and one of the it was very complicated why I left there. But one of the advantages I have now is I work in 4 locations. So it's easy to be busy 1 day a week in each of those locations because they're all doing their marketing. But some practices market phenomenally well, and the number of inquiries that come in is massive. But you still got to convert them. So I think it's a good TCO. It is good word of mouth. It's having lots of cases to show people, being approachable. But I think at the moment it's not relying on everyone to come on one location. So I'm generally busy in all clinics. I'm not generally busy in all clinics each month, but I'm busy in enough of them that it keeps me busy. And that also gives me the variety that I'm doing a lot of different work. So I think, again, it's a combination of things. It is having a good reputation, a good reviews, having a good reputation, and it's also working in a number of cases and working with good team members, good TCOs who do a lot of that for me.
David, thank you so much for this excellent presentation. I wish you a great evening, and hopefully we can have you back here sometime next year soon again to present on something else. It's been real pleasure.
All right, it's been an honor. Thank you very much.
If there are any other questions, we'll email them across to you, and if you have the time, please take from there. But thank you so much for an amazing presentation.
And thanks everyone for attending. That was helpful. Okay, thank you. Bye-bye.